most important one, systolic one. That's where it's most correlated with rupture, a shot in the systolic, not so much in diastolic. Diastolic is for long term, but acute episodes are the systolic that goes high and ruptures the vessels. So if the order is keep the blood pressure, the systolic blood pressure, less than 150s, and then there's a standing order next to it, say, if it gets to 150, start nitrite drip, so you bring it down. So if it's in the 140s, 143, 147, 148, 146, it's okay, but if it starts getting 152, 153, whatever, that nitrite drip should be started, and usually the order is titrate the drip. I can't tell you what's the exact dose. You know, you start the drip, you start with the low dose, start and keep the blood pressure until the goal is accomplished, which is the systolic goes lower than 150 or whatever the set parameter is. So pay 100% attention to the parameter, and if you start the nitrite drip, starting it is not just accomplishing the mission, you know, it's just step one. Then you have to do the following things: titrating it up and frequently checking the blood pressure, whether it's an A line, look at the A line. If it's a cough, frequently repeat the cough in order to get the number done, okay? You can't say, oh well, just I started it. Well, you started it, but did you recheck? Did you recheck it 10 times? Did you increase the nitrite? Did you get the job done? Did you accomplish the mission? No. You know, so it's just not just doing one step, it's doing constantly all the other steps and all the other follow-ups you have to check. There are frequently situations that there is a discrepancy between what the A line is showing you and the cough is showing you. Two solutions for that. Number one, call me. You have a problem. Which one do you want to go by, this or that? Okay? But if I'm not available, I'm not reachable for whatever reason you can't reach, the way to do it, do the safer thing. So what's the safer thing? For example, if the cough is showing 140, but the A line is showing 155, okay? So according to one number, you have to start some intervention. According to the other one, you should leave it alone, right? So go with assume the worst case scenario. Assume that, okay, so this is hypertension that should not be there, you know, go with the worst number. And then obviously after checking, making sure that A line is properly zeroed and it's a proper level, so the number is accurate, you do the initial things, but then if it's zeroed properly, it's positioned at the heart level, but still showing 155, and the other one is showing like 140, go with the worst number and start bringing the blood pressure lower, you know, so take that. But always call. So either call me or assume the worst, take action versus leaving it alone. Okay? So you will get to these scenarios that you don't know what to do, A or B. I'm showing you strategies here. So record the hourly neuro exam. So if it says in the first 24 hours or 48 hours, I can tell you, first 24 hours for sure, post-craniotomy, we would want hourly exam, you know, because a lot of things can go wrong. There can be a rupture in a blood vessel. There can be hematoma from just a tumor bed, you know. There could be a stroke that's evolving. So a lot of things can happen. You're not gonna have infection in the brain in the first 24 hours, but you're gonna have all sorts of other things that can go wrong after surgery that you need to be sort of like back of your mind, high index of suspicion, ready to recognize and pick up. So if it says hourly neuro exam, please do the hourly neuro exam and please document it, because if you don't document it, then you didn't do it, you know? And that's why this is another good reason to get a video at the baseline, you know, when you're starting your shift, when you're accepting this patient. You can always look at your own video, 1 minute video, no more than that, you know, and then at the end you can transfer it to the next nurse and delete it from your phone when you go home, you know. But it's very important to guide you, saying, okay, so record the drain output. If there is a there are three kind of drains which I will talk to you later in this talk. Whether it's a simple hemovac drain that's sitting under the scalp, whether it's a subdural drain, which is usually laying on a pillow next to the patient's head that doesn't need to be interfered with, or whether it's a ventriculostomy drain, which that is a sensitive one, and we'll talk about it, because the height of the drain versus the height of the head matters in that one case of ventriculostomy. But whatever it is, any of these three kind of drains, which I will go over the drains later in the talk, record it, please, okay? If it's 8 hours, record it. And then recording doesn't necessarily mean emptying it, okay? Because sometimes these drains should not be opened up to air because they connect directly to the brain. It can cause infection. Recording it is, for example, a subdural drain. It's connected to a Red Robinson catheter to a bile bag. You know, there's no suction, none of these have suction or anything because you can damage, injure the brain. So if it's sitting on the pillow next to the patient's head, there's a subdural drain. Recording it means that you lift it and see how much in the past few hours, you know, it's been accumulated, but doesn't necessarily mean open it, empty it, unless you have a direct order, okay? So because these have the direct short distance connection to the brain, you don't want to cause an infection. So record it only, but don't necessarily open it or drain it unless it's said so. So types of drain that you will see in the postoperative, you know. So subdural drain after subdural hematoma. This is a common one that you will see here. Okay, it's a Red Robinson catheter to a bile bag sitting on it. And it usually, you don't have to worry about the height of the bed, the height of the head, the height of the drain. It's just a little bag sitting next to it. And it accumulates itself over there. And usually we keep it for a day or two, no more than that. And I will show you the picture of that, you know. So that may need to be measured but not emptied. Okay, please keep this point in mind. Okay, the next one is intraventricular drain or ventriculostomy catheter, which I will show you the pictures, go over all this. And this intraventricular drain is a catheter that goes inside the brain, passes through the brain substance, goes into the ventricles, which are the cavities containing CSF, okay? And then comes out of the scalp, it connects to a chamber, which we'll go over all this. And this chamber, the height of that chamber does matter in relationship to the height of the head. Okay, so when I go over the pictures, I'll show you guys this. And then the last one, the easiest one is like a hemovac drain, which that is, you have a craniotomy, it's just a drain like any other drain that you put in the underneath the skin for draining the hematoma under the skin. And in this case would be scalp. So that's an extracranial drain. It's a drain that's just for blood under the skin or scalp, and it's outside the brain, outside the cranium. So that's the simplest. And if it gets pulled out, it's not a big deal. And this one doesn't have to be also adjusted for height of the bed or height of the head. Okay, so let's look at this. These are different kinds of hematomas. So here is the brain, the green is the dura, skull is the bony skull. So here's a typical skull fracture and an epidural hematoma. So it's outside the dura, but because usually it's from arterial blood, which is middle meningeal artery, arterial blood is fast accumulated. So the size of this can get very big and very major mass effect on the brain. So this is an emergency. There are some cases that you can have epidural hematoma like that, meaning outside the dura, and not be arterial, not be from the middle meningeal artery, and that's usually from bone bleeding. From the skull fracture, you can have slow growing. So that is a situation that you have more time, not so emergent, versus the arterial epidural. Then you can have, again here you see the green is the dura, underneath is the subdural space. So here showing that the hematoma, which this one is showing bluish. Why? Because it's venous, usually venous, but I'm going to show you a case of the emergency that we had. It was an arterial subdural. And usually, this is a venous hemorrhage, so that means a vein that was bridging from the surface of the brain cortex to the inner table of the skull, that vein got torn and caused the bleeding in this subdural space. But there are cases, rare, and I will show you one, that an artery on the surface can get damaged and bleeding, and this becomes an arterial blood clot, and that's a quick emergency situation, which is that case that I will show you here. So here is showing you, this is showing you exactly that scenario. Here is it. This is, both of these are subdural, underneath the dura, outside the surface of the brain, but underneath the dura. This is a venous type, leading from a ruptured vein. This is an arterial type, bleeding from injured artery on the cortex of the brain, still in the subdural space, you know. And these are the epidural, again showing you the same. This is a venous one, and this is an arterial epidural. So subdural, epidural, venous, arterial. Okay, now this is a different kind of hemorrhage, which is intracerebral or intraparenchymal. The white signal is the acute blood. That's how when we see it, this is a CT scan of the brain. This white is the calcium in the bony skull, and the gray is the brain. This cut is an axial cut. Imagine you cut the head like this and then look from the top. Okay, so this is the skull, the bony skull, brain, gray matter. This dark area is ventricle where the CSF is collected. So when you see a big whitish lesion or clot here, that's intracerebral hemorrhage. Most frequently from hypertension, okay? Uncontrolled hypertension, or people who have had hypertension for a long time, their microvessels, microcapillaries are very frail and very weak. So one episode of high systolic blood pressure out of control can rupture those tiny puny little vessels. And then the blood, which is supposed to be inside the pipes, gets outside the pipe, pours into the tissue of the brain, damages the brain. So this is an example of intracerebral. So you saw subdural hematoma, epidural hematoma, intracerebral hematoma. Okay, so here is a, do we have a, by any chance, a pointer? I don't know if she has a pointer. Oh, we have our, we have a hemo back here, that's good. It's okay. I mean, I'll continue.
I think it's right in between the projector and the laptop on top. That little brown, that case. Is it in there?
Let's see if it is. Thank you. Maybe. Looks promising. This is a. Oh, great. Thank you. So, okay, so now here's a, you can see an example of what kind of a hematoma is this?
Subdural.
Subdural, right. Why is that? Because here's the dura, this is the bone, the skull. The first layer is the scalp. So if you have a hemovac sitting underneath the scalp, hemovac like this, you know, okay, this goes under the scalp, and this is the reservoir, and you can have different kind of, we can say, put full suction, or half suction, or little suction, or no suction. No suction is, you just close this and don't put any suction into this, use it as a reservoir only, okay? So that hemovac sits between the scalp and the bone. So it's extracranial, outside the skull, okay? And it's only for draining the blood that will accumulate under the scalp. Now, if, then you have the skull, bony skull, then you have the dura. So if a hematoma was between the bone, inner table of the bone,